and any concerns and comments that you might be having. Dr. Christine Mose, we'll give you like 20 minutes to take us through your presentation, and then we'll address all the questions at the end of the session. Thank you very much. You could start.
Thank you, Dr. Kalondo. Nelson, are you able to make it full screen? Is it possible, or it is on my side? Dr. Kalondo, are you hearing me?
I'm working on it. Yes.
Yes, we can hear you.
So, Nelson, are you able to make it full screen? Or it is on my side?
Okay, I'm not sure if Nelson.
Dr. Kalondo, you've dropped off.
I'm not sure if Nelson, there seems to be an echo. Yeah, so maybe Christine, you could just continue as we wait for Nelson to figure it out.
Okay, so I don't seem to be able to control the slides on my side, so I'm depending on your side. So today I'm talking about nursing practice, implementation of patient-centeredness in delivery of care. And this is the topic that I was given. Perhaps, Nelson, you move on your side, the slides. So the primary goal of patient-centered care is to ensure that we improve the individual health outcomes. If we apply also the patient-centered care will also improve population health. And at the same time, patient-centered care is known to have some benefits for the healthcare workforce as well as the health systems. This is regardless of the cadre of the healthcare giver, and regardless of the size of the institution. If patient-centered care principles are applied, there are benefits to the clients, their relatives, the whole population in the society, as well as the healthcare workforce and the health systems themselves.
Christine, are you okay?
Yes, I'm fine, but I'm not able to move my slides. So I can't control the speed at which I move.
Okay.
So patients, yes. So as an introduction, patients and family-centered care encourages the active collaboration and shared decision-making. This is between the patients, their families, and the healthcare workforce. And they work together to design and manage a customized and comprehensive care plan. So whether it is moving from the planning, the implementation, the evaluation, and even the discharge of the patient, the three form a collaboration that is going to drive the care of the patient. And patient-centered care is helping us to shift away from focusing on the disease so that we focus more on the patient, their families and guardians, and even other significant people in their life. So we build partnerships between the patients, the families, and the healthcare team, whether it is a pharmacist, whether it is the physiotherapist, whether it is a cleaner, we form a partner. We form a partnership that is going to help us all. This is providing quality healthcare from the patient's perspective. So we move from the paternalistic level and we step into the patient's shoes and walk with them, even as we apply our professional knowledge in the care of the patient. So we provide quality healthcare in the patient's perspective, And this is through shared decision making, through optimal viable decisions. Of course, we have to do this using viable decisions. So in patient-centeredness, we are saying that we must consider what the patient's values are, what their preferences are, what they express as the felt needs, and then we also must consider integrated care. For example, we are opening a new hospital soon that is a pediatric hospital. We were asking ourselves this morning, here comes a mother who has delivered, they have a sick baby, they need family planning and postnatal care. What about integrating all the services so that under one roof, the patient is able to get that? Then the other aspect is providing information and education, the physical comfort and pain management of the patient, the emotional support to alleviate any fear that the patient may having, taking away every anxiety, sometimes not able to take it all away, but at least reducing it. And at this time, we also must involve the patient family members, their friends as appropriate, to ensure that care is continued. Therefore, we must also look at the referral system. We must also consider the patient's care between discharge. And also we need to consider the access of care. This is a physical access and other forms of accessibility to care. For example, the transport, where we have put Kenyatta National Hospital, where we have put Mama Lucy, is it accessible to the patient who is coming from maybe the slum that is around there? Then the other aspect, you find that parties, they share information. The healthcare giver will offer the options that we have. The risks and the benefits are considered by all parties. And then the patient will express what their preferences are. Maybe the healthcare giver thinks this patient will benefit from an operation, but the patient is asking, is there another option? Can you treat me? Not necessarily take me to theater. And then their values also must be considered. Of course, we know some values can be contradictory in terms of what we consider to be objective professional care, but now that will be handled at the level of ethical dilemma. And when this is done, when what I've been talking about is applied, you'll find that the result is, we resort into better understanding. There's shared responsibility between the parties, and implementation and evaluation and interventions are applied collectively. We then raise, as we are sharing the information, you find awareness is raised. We create an increased understanding among the patient, the significant others, and other persons that are in the picture. Nelson, are you able to hear me? I can see you're ahead of me. Hi, Dr. Kalondu, am I audible?
Yes, you're very audible. We can hear you very clearly.
Okay. Okay, thank you very much. And when we raise awareness, then we create increased, sorry, I've tapped what I shouldn't have tapped. My screen has gone small. This increased understanding, and through discussions, through questions, and through other ways, you can even show the patient videos. You can write if writing is going to help, and you can also help other patient decision aids to help this patient to make an informed condition. Nelson? You find that for us to be able to apply patient-centered care effectively, then the barriers that have been existing between healthcare givers and patients and their significant others, they need to be addressed. Some of them, we already know them. Others develop as we continue to give care. And therefore, those ones must be addressed adequately. And the patients ought to be sensitized regarding the critical role that they play in patient-centered care. They need to be told the options that there are, the consequences, the risks, and the benefits that they are likely to have when we take the different options. The healthcare workers, on the other hand, they need to relinquish the role that they've been assuming. For example, I'd mentioned the paternalistic role that sometimes we play in the healthcare system, and we need to drop that as much as possible, and we become coaches and partners with the patient. Where, you know, like the way in a football match, you have the coach. Yes, the coach may be knowing more than the people he's coaching, but he also knows that these people, they also have a role to play, and we become partners. Healthcare workers, they also need to learn to ask certain questions. And this I found in some researches that have been carried out, that as healthcare workers, for us to be effective in terms of giving patient-centered care, we need to ask the significant others and patients, what is important to you? It's not about me now, it's not about my institution, but it's about you. What is important to you? How would you like this done? When would you like this done? And by whom do you want this done? And this causes the patient now to feel that they are empowered, and that whatever decisions they bring on board, it is going to be considered. Evidence shows that when we view the healthcare experience through the patient's eye, we will become more responsive to their needs. And being responsive, it means we are listening to the client. We are hearing that they are saying they have pain. I'm saying I gave, for example, an analgesic 2 hours ago, but the patient is saying, no, despite that, I'm still in pain. And therefore, I will respond to the need of the patient in the patient's eye. And we will be able to give better health care, and also our institutions will become important. When I was looking at this, I realized that shared decision is pivotal when it comes to patient-centered care delivery. Nelson? So there are several elements that influence how healthcare systems are designed and managed, and how the delivery of care is provided. And in regards to patient-centered care, the mission, vision, values, leadership, and quality improvement drivers of that particular institution is very important, because if the hospital's mission, vision, and values and leadership are driving patient-centered goals, we are likely to end up having a patient-centered care delivery. The other thing that is important is collaboration, coordination, and accessibility, and also the right care being provided at the right time and at the right place, depending on what the partners, the collaborators of this patient-centered care have concluded at the end of the day. Patient-centered care also focuses on physical comfort as well as emotional well-being. Patients and family preferences, values, cultures, and traditions, social economic conditions are also respected in regards to patient-centered care. Patients and their families are expected also to be part of the care team. And I think I'm just repeating this as a way of emphasis. And the presence of a family member in the care setting is encouraged and facilitated. And we know this was compromised because of COVID-19, when we needed to really control visitors. The presence of family members was not allowed all the time. And even when we required more than one person as a family member, this was not possible. But now if we discuss this with the patient, why we are doing this, and also when the patient listens to the news and they hear the guidelines that are being given by the Ministry of Health, they are going to understand why we are doing what we are doing at every different time. Information must be shared fully, and in a timely manner, so that a patient is not asking a question, why did I go to theater when they've already gone to theater? Let us be timely to explain why the patient must go to theater if they must go to theater. And when we do this, we find that our patients will resort to informed decision making. Next, Nelson. And this is just a summary of what I've been talking about, the elements that are considered when we are applying patient-centered care, the mission, the vision, the values that are aligned to patient goals, and then the collaboration and the coordination, physical comfort and emotional well-being, the patient and family viewpoints being respected and valued, then the patient always being included in decision making, and the family being present at the care settings, and full transparency when it comes to giving information and creating awareness to our patients and their significant others. Nelson? There are 8 principles that have been considered by PICA and which help to facilitate or to drive patient-centered care. And these include respect for patients' preferences. Maybe I don't need to labor on that more. The coordination, the integration of care, the information and education to the patient, the physical comfort, emotional comfort, involvement of family and friends, continuity of and transition of care, and access to care. Now, when it comes to continuity and transition of care, this patient at one time is in the hospital. Sometimes they transit to home-based care, but sometimes there's also the referral system. The referral system also needs to be aligned so that it takes care of the needs of the patient. Then for access to care, here we are talking about, is it near where I live? Is it affordable? Like now we are talking about universal health coverage. Is it affordable for the lowest mwananchi who is living at Mukuru, was born there, is working from house to house, maybe washing clothes? Accessibility is also about transport. If I need first aid, there's been a fire at Kibera, is the ambulance, when I call the ambulance, are they able to move to Kibera and do first aid or rescue me to the hospital place? Let's move on, please. So what is required to succeed in patient-centered care are 3 relational dimensions, and they've been summarized here. We need to have shared goals. We need to have shared information or knowledge, and we need to have mutual respect. The healthcare giver, I respect the patient, I respect the relatives and the significant others, but I'm also sharing knowledge. What I know, the patient is also sharing, and they are shared goals, which are based on the information that has been obtained from the healthcare giver and the patient and their significant others. Next. So in Kenyatta National Hospital, in terms of nursing care, how are we applying patient-centered nursing care delivery? And we have picked this and put it in the mainstreaming nursing process, or if you want, you just call it nursing process. This is a journey which we started in 2016. We asked ourselves what the gaps were and why our patients were not getting patient-centered care. And therefore, we looked at the models of nursing care, and we picked the nursing process. The nursing process is a way of being able to get information regarding the needs of the patient, discussing with the patient and the relatives, looking at the investigations that have been done, and the radiological exams that have been done, the findings of the physical exams that we are doing, what the patient is saying and not saying, and then putting that all together and developing nursing diagnosis, which are prioritized to what is actual and what the patient is at risk of and what is potential. So this is a journey we started in 2016 in general and specialized surgery. Later, it has moved to KPCC, Obs-Gynae, orthopedics, medicine, have been trained and are being mentored right now. We are looking forward to having this in the accident and emergency department, specialized medicine, and pediatric departments. So in summary, it is a way that we assess the patient using objective and subjective data. And the subjective data is what the client is saying. The subjective data is what stems from the patients themselves. Then the objective data is what we can observe, what we can pick from the X-ray, what we can pick from the what the labs have found. And after assessing all that, we put all that together and we group it into cues, and the cues give us a nursing diagnosis. After it has given us a nursing diagnosis, then we prioritize the nursing diagnosis that we have come up with. For example, the things that are associated with A in terms of airway, they take the priority. The B, they take the priority number one, the B of breathing, then the cardiac issues, circulation issues, and we move on until the end. So we put the A items, the airway items as number one, and we move all the way to the end of the priority list. Then after developing the nursing diagnosis, then we plan our care. Remember, as we are moving from the assessment to the planning, to the implementation, to the evaluation and the documentation, we are working hand in hand with the patient, we are working hand in hand with the relatives and the significant others. And therefore, after assessing, we come up with the nursing diagnosis, then we plan the care. We plan the care and we prioritize what must be done first, and then we implement. During the implementation, I want to say, we also consider the healthcare team, because there are things that the nurse will do alone and things that the nurse needs to work with the physiotherapist, with the clinical officer, with the medical officer. So we consider those items that are independent and the things that are collaborative. Then after implementation, we continuously evaluate, still using subjective and objective data. Then we document. Documentation in nursing is very critical, because we know you've not documented it, it is considered you have not actually done it. And therefore we continuously document. I was in a place where some nurses and doctors were speaking, and one doctor said that you have to be careful when you're dealing with a nurse, because they might put it in the cardex. The doctor said that for us in nursing, documentation is very critical, including even the conversation on the phone, the conversation in the email and otherwise. So documentation comes in. And I would like to say that nursing process has been domesticated, and we have nursing process, the Kenyan model. The Kenyan model is the one that included documentation. Documentation was not there initially. And I would like to say that to begin with, we were using external trainers, but now we have trained our own, and we can train ourselves, and we can even train other institutions. Let's move on, Nelson. Nelson, please. So as we look at patient-centered care, I would like to bring out some of the benefits. We find that the patient and the families are more satisfied. The healthcare workers, they get a better reputation. among the recipients of care and other stakeholders. You find also the morale, the productivity and job satisfaction of the healthcare workforce improves. And there is a better, we form a better basis to do resource advocacy, and also allocation tends to improve when our carers are talking well about us. There is reduced expenditure and loss because there's no repeat of jobs, of work, repeat work. We are not going to make mistakes and do it again. And the return on investment also tends to improve. There's mutual accountability. And you find the patient is open to express both positive and negative aspects of the care. And you find that their experiences can be improved, and also where redress is required, it can be applied. Learning is advanced and adverse effects are also reduced. The care is tailored to patients' needs, and the quality of care improves, and we get better outcomes. And these are just some of them, there are more than this. Therefore, patient-centered nursing care has become an integral part of our global care, whether you're in the clinic or whether you're in the inpatient setups. Patient-centered nursing care has become part of us. It has found a home in Kenyatta National Hospital, and we are using the nursing process to implement nursing patient-centered care. In addition, I would like to summarize by saying that it requires three main items, and this is shared goals, shared knowledge, and mutual respect. Thank you very much.
Thank you very much, Dr. Christine Muse, for that presentation, and we've heard you. Some of the keywords that I've gotten from you, there are quite a number. You've talked about shared decision-making, collaboration, partnership, building partnerships with the patients, their families, and healthcare workers, and considering the patient values, preferences, and expressed needs. You've mentioned about access to care. You've talked about information sharing and shared responsibility, and being responsive to client needs. And then the three things that we require are shared goals, shared knowledge, and mutual respect. Thank you very much for that. As Nelson adds the next presenter to the panelist section, we have Julie Matiba and Dr. Rosemary Wanjiru. Nelson, kindly, could you please add them to the panelist section so that they can prepare for the next session? Thank you very much, Nelson. So Christine, I'm not seeing any questions at the moment, but just to emphasize on that, and I like what you've said about information and access to information, and even the journey that nursing standards or nursing care has taken through KNH while mainstreaming nursing processes. Maybe just as a brief highlight, what are some of the challenges you've encountered in this process as you are implementing the nursing standards, so that if there are any nurses logged in, they could learn a thing or two? I'm sure it's not been a smooth journey from 2016 to 2022. It's now 6 years. What are some of the challenges and the good things that you've also learned along the way? Maybe you could share briefly as Julie projects her screen.
Thank you very much, Dr. Kalondu. It's not been a smooth journey, but it is one of those journeys that has been very beneficial. Some of the benefits, the patients have become more open and they can be able to express themselves. Number two, we are able to get more information regarding making the nursing diagnosis. We are able to prioritize the care of the patient better than we were doing before, because before we were just going to assess the patient, not getting a lot of information from them and assuming that we know what their priorities are. Now the patients can say what their priorities are. And then in our evaluation, we are able to tell which interventions are more effective than others. Of course, this is not to say that it is all smooth sailing. We've had some challenges. Some challenges have been issues of documentation. You know, the workload and the very sick patients that we deal with in Kenyatta National Hospital, and therefore the patient-nurse ratio has been an issue. Therefore, documentation sometimes becomes the part that is compromised. The other thing is just the patient-nurse ratio, so that our patients are so many. And even though we categorize our patients so that category A must get the nursing care plan as a must, you find sometimes you have so many patients, especially after being on call, all patients requiring the nursing care plan, and therefore it can be overwhelming when you just have a few nurses on board. And of course, as all other changes, you'll find a bit of resistance. But if you give information, you find the resistance wears off even as we persist. Thank you.
Yes, thank you very much. And I like your last part. As we give information, the resistance wears off. Change management is not the easiest aspect of healthcare or any organization. But as your last point says, as we give information, you find that resistance changes. And Millicent, Matthew, yes, this is being done at a public hospital. And we hope that it is something that we can all learn from and see how well to implement it in our other facilities. I'm seeing the presentation for Julie on the screen, and Julie will be giving us a more practical approach of a study that she's done. And this hopefully will address a question that I've seen where somebody's asking about benefits of patient-centered care. We will address all the questions at the end of the session. The panelists will still be here until the end. And we hope that by the end of the session, all your questions will be addressed. So Julie Matiba has done research on patient-centered care, the gynecological wards at Kenyatta National Hospital. And Julie, if you're online, you could take us through, introduce yourself briefly and take us through this session. Karibu.
Thank you. Thank you, Dr. Kalonzo. Hope you can hear me.
Yes, we can hear you, but you're a bit faint. Maybe add a little more volume to your end.
Okay, maybe I'll talk a bit loudly.
Okay.
Thank you so much for this opportunity. I'm humbled and I'm proud to be part of this team. So my name is Julie Matiba. I'm an oncology nurse at Kenyatta National Hospital, currently working at the Clinic 66, where we do the cervical cancer screening, among other services. I'm also a mother. I'm also, well, a daughter. I have many other roles that I play. But today, my role here is to share a study that I did in 2020 on patient-centered care. Since I'm an oncology nurse, I was more biased on the cancer care because that is my line.
Julie, sorry to interrupt you. I know you're very soft-spoken in real life, but there's a request that if you could move closer to the mic, people cannot hear you very clearly. You're very soft-spoken in real life. And we just hope that people could be able to hear you clearly on this presentation because it is a very good presentation.
I don't know whether that's much better.
Slightly, yes, there's improvement.
Sorry, Dr. Kalonzo. I'll proceed. So like I said, I did my study on cancer patients because that is my line of specialty. Next. As an introduction, maybe this will be more of a repetition from what my senior has said. Patient-centered care is a healthcare approach that treats patients with high regard by listening and educating them and considering them, the patients and their significant others in all decisions about their management. That means we are partners in their care. So whatever decision we make, we involve them or their significant others. Next. And patient-centered care can be perceived either positively or negatively, depending on the outcome of the illness. So in this study, we established the patient's views. And this enabled us to identify the gaps or barriers in service provision and improvement areas which if resolved, like we were told, will enhance the quality of health services provided and improve the clinical outcome. In the long run, we'll have better health systems and better, happier patients. Next. So this was my broad objective, and I wanted to determine patients' perception on the quality of patient-centered cancer care in the gynecological wards at Kenyatta National Hospital. Next. And I had specific objectives. Now, these specific objectives were aligned to the principles, like my senior has just said, the principles of patient-centered care. So one of the objectives was on holistic care. Holistic care because I combined physical comfort and emotional comfort, and I also added spiritual comfort. These are key areas in cancer care, and that is why I concentrated on patients' view of holistic care. Also determined the patient's facilitators and barriers to explode, the patient's perceptions on facilitators and barriers to healthcare provider stroke patient communication. Communication is very key, like we were told. Another objective was to determine patients' perception on the respect of their values, preferences, and their expressed needs. This is in the principle of respect for patients' preferences. Our patients are human beings. They have their needs, they have their values, and we also needed to explore that. And finally, we explored the family involvement. Family involvement is key when you need to take care of the patient, especially during discharge, in continuity and follow-up of care. So those are my main objectives. Next. So my methodology in brief, this was a qualitative study of phenomenological approach. That means we got the patient's lived experiences. These are patients who have already been on treatment. And we did in-depth interviews where the patients gave us word verbatim of what they were experiencing. And the study area was the gynecological wards. That included ward 1B and 1D, where we have oncology, gyne-oncology patients. And the population, the sampling, we did 19 women who were on treatment for either gynecological cancers, either surgery, chemotherapy, or radiation therapy. The sampling technique was consecutive or purposive sampling, where we purposely identified the suitable clients. And the study instruments, we used an interview guide as well as a mobile app. People use a recording device, but I got to get a mobile phone app. Next.
Julie, as we go to the next slide, and thank you for your presentation, I'm seeing there are a bit of concerns about people not being to hear clearly. Listeners, participants, Julie is very soft-spoken, and trust me, when I say she's shouting, she is actually shouting at the moment. She's very soft-spoken, so it's a kind request. If you're able to adjust the volume from your end. Yes, Julie and also the participants, if you can increase your volume slightly so that you can hear this great presentation a bit better, that would be great. Thank you for understanding, and thank you for adjusting on your end. Thank you. Julie, you can proceed.
Thank you. I'm also trying to see how I can add my audio volume. But from my end, it looks like it's completely on the higher side.
Yes, that's what I'm saying. I know you're shouting, so we will try and adjust also from our ends and hear your presentation. So please continue. Thank you.
Okay, I'm so sorry about that, but I'll scream as much as I can. So we have talked about the methodology. Now let's go to the results. So the themes, like I said, were aligned to the study objectives, and the emergent ones were identified and organized into sub-themes as appropriate. 5 main themes were identified as per the objectives, that is holistic care, experiences in communication, respect for patients' values, preferences, and expressed needs, and involvement of the family. Next. Next. Okay, thank you. The first objective was looking at the patient's experiences with holistic cancer care. And the first one was physical comfort. We evaluated how the patient was feeling about pain management, about assisted toileting, and generally how the environment was. From the patient's views, the pain was well managed. I can quote that: when in pain, the nurses give me painkillers. And for assisted bathing, assistance with bathing and toileting was offered. However, some felt there was no privacy and the environment was clean. That was for just physical comfort. Next. Next.
Nelson, how are you? Hello,
As we wait for
Nelson.
Nelson,
Yes.
physical comfort is very, very important in our patients' experiences, and how they perceive them is how you treat them. So if you treat them negatively, they will feel they are not comfortable physically, and if you don't, then I mean, of course, this affects how they feel. Then we also dealt with psychological issues, how they perceive the psychological issues were dealt with. One of the respondents says, I really don't know. I have not seen any counselor, or maybe it is because I have not stayed long. Okay, this is a patient who had not been in the ward for so long, but had already started treatment. And then one on self-care said, we usually share with other patients who are in the ward. This helps us a lot. I also talk to my family and friends. This is a form of, taking care of themselves. While in the wards, they bond, they talk, and they share their experiences. Others keep to themselves. I just keep quiet and keep to myself. I don't talk to anyone because I prefer to stay silent as I am not comfortable sharing with another one. That's another respondent. So all these are how this shows that there is no psychotherapeutic interventions offered. Next. Next. On the holistic care, we also looked at the spiritual care, how the patients perceive. One respondent said, there are nurses who don't want us to pray loudly. They say we pray silently in our hearts. There are many reasons for that, but that's the patient's view. That means there was insensitivity to their spiritual needs, lack of in-hospital spiritual care. No one from the hospital chaplaincy comes, but I am in touch with people from my church. We talk and they encourage me through the phone. Another respondent saying they seek their own kind of spiritual care. And then, of course, there was the effects of COVID on spiritual care. During this time of COVID, I quote, the preachers do not come. This study was done in 2020 when COVID was right at the beginning of the pandemic. So this affected also how people were allowed into the wards, how the chaplaincy walked into the institution. Next. That was about holistic care. Now we go to the patient's perception on facilitators and barriers to healthcare provider and patient communication. So communication is very key in patient-centered care. So only one facilitator was identified from the patients, and that was response to inquiries from the patients. I quote, most of the doctors who come for the ward rounds are always ready to answer my questions when I ask. That's one respondent. And another one said, when I have a question, the doctors or nurses always answer. And I think this is a very good thing. When you respond to patients' inquiries, they are comfortable. Next. So that we only found one facilitator, but several barriers. Now, one of the barriers was busy schedules of healthcare providers. And I quote, if I have a question, they have an answer. But sometimes when they are busy, it is difficult to ask. Another one is preconceived notions about patients' understanding on care. But some will not tell you anything because they assume you do not understand. All these are patients' perceptions about our care. Lack of involvement in care planning and shared decision making. This is a patient who was concerned because he says, I came for chemo, was admitted for chemotherapy. Then the doctor decided maybe he saw the wound was shrinking too fast, and then he decided to do surgery. That means there was no communication. Why not chemo and why surgery? So another barrier to communication. We are not giving them information. We assume they don't know, and sometimes we are too busy. Next. Another theme was information hoarding. They didn't tell me whether I will continue coming for daily wound cleaning or I will be coming to the clinic after discharge. They just left without explaining. This shows that we are not giving them all the information that they require, especially if it concerns discharge. Sometimes we wait until the day of discharge, and that's when we are giving some information. Another sub-theme was assumptions by healthcare workers. The nurses assumed I am aware of it. They just asked what I had come for and did not explain further. Again, we are not giving all the information. We make too many assumptions. Provision of incomplete information concerning care, like I mentioned. I was informed the chemotherapy would make my nails turn black and cause a lot of nausea and vomiting. Nothing about my hair. This was a young girl who is concerned about her physical appearance, and yet nobody told her that her hair would fall off. Another very important concern. Next. Now we go to the next theme, which was respect for their values, preferences, and expressed needs. One of the clients said, they will always ask how I'm feeling, and they explained how my disease is because they have the gadgets. That was her feeling. She felt patients were involved in her care. However, another one said, addressing self-care needs, they have not been rude to me. I've been given warm water for bathing and good clothes to wear. Again, they perceived their values and their preferences were being met because of the way they were handled. Empathy, some felt that there was a day I was not feeling well and I remained in bed. The nurses were concerned and came to find out what was wrong. And the third one nurse came and really insulted me until I asked myself, Gaki, surely, do you know the suffering I have undergone? So all these patients are different. They come from different areas. They have different needs. And this is how they perceive our care. So let's move on. And the last objective was family involvement, how our patients perceive how we involve the family. One said they are all supporting me. They are all supporting me because now, even though those medicines, my grandmother, she's the one who bought me drugs. This is what verbatim of what our patients are talking about. Of course, some of them, the language was not very fluent, but you can see the message. We have not involved their family. Another one says, the healthcare workers do not communicate directly with my relatives. I'm the one who tells them how I'm doing. If anything is needed, I call my relatives to come. We are not involving the family. And like one of the principles of patient-centered care says, for continuity and transition, we must communicate. We must involve the family and friends and other significant others. Next. Next. So in my discussion, this is what I found. In this study, patients' positive experiences with holistic cancer care was closely coupled with improved overall health and quality of life following care and treatment at the facility. This just tells us that on holistic care, depending on how the outcome was, if they became better, if there was no pain, if the environment was clean, they valued it as good care. That is for holistic cancer care. Next. Now for communication, like I said, there were barriers and there were facilitators. So this study established that responding to patients' inquiries was the main facilitator to good communication. However, there were several barriers to communication. One was busy schedules of healthcare providers. There was preconceived notions about patients' understanding and assumptions. made by healthcare providers and information hoarding. This just makes us reflect. How are we talking to our patients? How are we giving them information like we were told? They need that information. They need to be made aware and to the level of their understanding. Some are elderly, some are young, so their level of understanding is different. Their background is different. They have low esteem because of the low education levels. So all these are things we needed to consider when we need to consider when we are giving information to our patients. Next. Another one was we looked at the respect for values, preferences, and express needs. These were perceived as present or absent by how the healthcare providers communicated and with the patients and how they treated them. So did you communicate? Did you treat them with respect? That is how they value your, that is how they felt their values and preferences were met. Another reflection comes there where how do you ask your patients what they want? Do you listen to what they want to tell you? Sometimes we just assume and just give information and walk away. Sometimes it's good to listen to them and find out what their feelings really are. What do they want to do that you're not allowing them to do? Next. Next. Oh, okay. Family involvement. So none of the interviewees reported direct involvement of their family members by the healthcare providers. Now, these patients are usually escorted to the hospital. Unfortunately, this was during the COVID pandemic, at the climax of it. But these patients will still go back to the community. These patients will still need follow-up. And unless we engage and involve the family or significant others, then there's no way they will, there's no way they will get the complete care. There's no way we are giving patient-centered care if we are not involving either the son, either the spouse. Talk to the family member who will be the caregiver when, especially they get discharged, when they need to go and come back. They need proper communication. They need to be involved. Thank you. And next. So in conclusion, from the findings, the quality of patient-centered cancer care provided in the gynecological wards at KNH, as per the perception of the patients, was below average. So to ensure quality patient-centered cancer care, all healthcare stakeholders need to be involved. This means it's a multidisciplinary team dealing with this patient, and they need to give patient-centered care. Thank you. I believe that's the last slide. Thank you.
Thank you very much, Julie, for that wonderful presentation. And thank you for evidence-based research. This informs need for policy and need for us to interrogate our system. And I like that you were able to bring out the quotes by the patient just as it was in that focus group discussion, and just the way the patient said it, exactly without paraphrasing it. So as Beatrice said, this is excellent information, simple, but greatly impacts patient care outcomes. And Julie, I hear you very loud and clear about involvement of family, about communication, about respect for values and preferences, and also about communication. How do we communicate to the patient? Access to information. And this access to information is what facilitates them to make informed decisions. So as Nelson loads the next presentation and invites Dr. Wanjiru to the panelist section, I'd like to see if there are any questions. Okay, so there are two questions and a comment in the Q&A session. And I'll read the comment first. The comment was that from Ruth, and she said that she likes what has been said about planning of care using the ABC. It makes it very easy to plan without missing out on anything obtained from the nursing diagnosis. So there are two questions, and one is asking about benefits of patient-centered care, and the second one is asking about drawing the line between patient confidentiality and involvement of family members. So as Dr. Wanjiru prepares a slide or comes on next, we could be thinking, and you'll answer the questions together with Christine Muse and Ann Kirema at the end of this session. So Dr. Wanjiru, karibu sana. You have 20 minutes. It's now 3 p.m. So karibu.
Okay, I think I need to stop my share. Good afternoon.
Good afternoon.
Do I share screen or they will?
Yes, you can share your screen from your end.
Okay, fine.
Really, yes.
Thank you. Everyone can view it?
Yes, we can see your screen.
Okay, thank you very much for inviting me to participate in this very important topic. And I'm representing the diabetes clinic, which will represent one of the NCDs. There are very many NCDs, including the cancer care that has just been discussed. And my previous presenters have done an excellent job and will make my work much easier. So we will look at our diabetes care journey at the KNH Endocrinology and Diabetes Clinic. So just a bit of introduction is that there's been a big growth in the last 3 decades of different treatment options, different ways of checking your blood sugar, and a lot of knowledge has increased. But still, many patients with diabetes are not meeting evidence-based goals, and they still continue to experience a lot of complications, with most of them being preventable if their care was better. Now, we have a big discrepancy between optimal control and actual control that can be attributed to many variables. And some of these variables will include either the clinician who's taking care of the patient or the patient themselves or different system factors. And in the center of all this is having a patient-centered approach so that you can get better care for our patient. So different studies have been conducted, and one study was looking at patient-centered care in patients with type 2 diabetes, and it found that when you have a patient-centered care, you increase the patient satisfaction, you improve the patient-provider communication, and overall you have an enhanced patient well-being. And for you to give patient-centered care, the provider has to understand the patient as a person, and the way that patient experiences the disease is very crucial for you to be able to give the best care for that patient. Different patients experience different illnesses in individual ways, and that personal narrative can motivate behaviors or decisions that will influence the healthcare. Therefore, the key where we say diabetes is that you have to individualize the care. You cannot give the same care. So the model we use is a one that has been approved by the American Diabetes Association. And what we do is that initially when the patient comes, we look at the patient characteristics. You have to look at the patient's lifestyle, the different comorbidities, because the patients are different. You have one patient who might be having chronic kidney disease, vis-a-vis a patient who has heart failure, vis-a-vis a patient who is an amputee, or a patient who has visual loss. You cannot treat them the same way. Their lifestyles are different. You have a busy medical person vis-a-vis someone who stays at home and is immobile or has had a stroke, or someone else who works in a bank where they don't even get lunch breaks. So you have to individualize. You have to see their different characteristics. You have they look at the clinical characteristics. What are their age? What is their weight? What is their HbA1c? Issues like motivation and depression, culture and socioeconomic context, where you find there's some communities, if you have to start a patient on insulin, some communities might already think that now patient is terminal and their life is coming to an end. Then you consider specific factors that will impact your choice of treatment. You individualize your targets. If you have a cancer patient who has been diagnosed with diabetes and has metastatic disease, you're not going to have the same targets as a type 1 diabetic patient who's been diagnosed at 17 years of age. You look at the impact of the treatment on the weight and hypoglycemia, because we want good treatment, good care, but we avoid hypoglycemia because there's no hypoglycemic episode that is benign. You look at the side effect profile of every medication. If you have a heart failure patient or a chronic kidney disease, you cannot treat them the same way. You look at the complexity of the regimen. You might find the patient is illiterate, and therefore giving them a very complex regimen, or a patient with cognitive dysfunction will eventually make your patient either to double dose or underdose the medication, which will give you worse outcomes. Then you choose a regimen that will optimize adherence and persistence. Again, you have to look at the access of that medication, the cost and availability of that medication. You cannot give a patient a medication that is not going to be available or which they cannot afford, where you depend on donors. You have to have a sustainable way of treating this patient. And then the next thing, which is very key, is that you make a shared decision making and create a management plan with this patient. And that is when you inform, you have an educated, and when we talk about educated, it's not the level of education, but a patient who's been educated on their diabetes, has been educated on their comorbidities, therefore is an informed patient. And if possible, you want them to have a family member or a caregiver with them so that they can support each other. You seek the patient preferences. If a patient does not want injectables, you want to find out why is that patient resistant to the injectables? Is it the meats that have been given by other patients, so that when the patient takes the medication, they're adherent. You want to have effective consultation that will include motivational interviewing. You set goals with the patient and have a shared decision making. Therefore, you empower the patient and make sure that the patient has got diabetes self-management education and support that is continuous. After that decision making, you come up with a management plan that is SMART, meaning that it is specific. You have certain goals, you have measurable goals, you have achievable and realistic goals, and it's a time-limited goal. You want to tell the patient that you have started with a HbA1c of 10%. We want in 3 months' time to repeat your test and see whether we are getting better with this new regimen. So it has to be time-limited. And you implement your management plan and continue monitoring and supporting, including the emotional well-being, checking on the tolerability of the medication. You don't want patient to be maybe on metformin high dose, and this patient is having diarrhea, and you keep telling them, since your sugars are excellent, we're going to continue. You have to give them medications that are tolerable and give continuous biofeedback. And you keep reviewing and agreeing on the management plan and have mutual agreements on the changes. And you have to avoid clinician inertia. And this decision cycle ideally should be undertaken at least once or twice a year. So what about now the journey at KNH? How do we go about it? Initially, the patient will come with a consultation either from casualty, from the clinic, from the ward, or from another hospital. And we encourage the referral so that we are able to focus on the patients who really need this care. Because if we are taking care of all the patients, then we're not able to be effective. So you find that most of our patients are complicated and you need a lot of time. Once the consultation is brought to the clinic, the consultation is signed and the patient is asked to book an appointment by opening a file. But each patient who comes to the clinic will have their vital signs taken. They will have a random blood sugar taken. They will not go away with a sugar of 20, 30, or even 16. If the sugar is elevated, the clinician who's running the clinic will definitely review the patient. But if the patient is stable, then they can be asked to be booked. And it depends on the severity or the urgency of the booking. Could be from 1 week to a month. After that, before the patient goes away, we usually request the clinician to request the patient to go with a laboratory request form, so that by the time they're coming back, then it is an easier way of reviewing. You don't want now to see the patient for the first time, and then now you tell them you need to go and come back with kidney function test so that I can decide which medication to give you. So the baseline tests that we usually request for are kidney function, a urinalysis, and the HbA1c. But of course, all these are dependent on the financial capability of the patient. There are still other tests that we request, but those are the baseline that will help us determine the medication that the patient requires. In the diabetes clinic, we have mini clinics which are run by our clinicians that
Hello, Dr. Wanjiru. Hello, Dr. Wanjiru. Okay, we seem to have, she seems to have dropped off a bit, probably network challenges, but as we wait her to come back and finish this session, which is very informative, we'd like to start thanking Patient Affairs for organizing this and for bringing awareness into the involvement of the caregiver in this process. Dr. Wanjiru, are you still there?
Yes.
Good, great.
Sorry, where did I lose everyone?
We had on our screens, we had the KNH process, and
okay.
You explained about the consultation process.
Okay, so once the patient has been, maybe let me just go back. We get the patient coming with a consultation, it's signed. And each patient has a random blood sugar that is evaluated, so that in case the patient's sugar is elevated, then they don't go home, they are reviewed. If the patient has anything else, like the blood pressure is elevated, they are reviewed. And each patient is reviewed by, is referred to the main clinic, which is run by the consultants and the other doctors, but the whole team is involved. And the main clinic is where the treatment plan is outlined so that they can be followed up. But there are also minor clinics that are run by the clinicians and are run daily. Then each patient is advised to book for a diabetes education, which is run by the diabetes educators, the nurses, the food specialists, the physiotherapists, and the nutritionists, and it's a whole day affair. They start from 9 a.m. to 3 p.m. And here the patients also tend to meet with each other and form support groups, and you find that they become very reassured when they meet each other and realize that the diabetes is not a killer and can be managed well. And when we give referrals, we give referrals for the, not referrals, but when the patient has been seen in the main clinic, you book them to attend a main clinic and a minor clinic. The minor clinic is every day, therefore the patient can be seen more frequently as compared to the main clinic, which is only on Friday, so the patient cannot be seen as frequently. So when you see a new patient, it can take even 1 hour, from 20 minutes to 1 hour, dependent on the complexity of the patient, dependent on the comorbidities the patient has. And that's where sometimes you might see a consultant has only seen 4 patients and you wonder what were they doing the whole time, but it's because of trying to get this treatment plan. The team is big. We have doctors and clinicians, nurses who are educators and food care specialists. We have the pharmacists and pharmaceutical technologists. We have the nutritionists, we have the counselors, we have the physiotherapists, we have the health information records, we have the laboratory staff, the phlebotomists, our support staff, our finance clerks. We have retinal screening, which we do at least once a year or even twice a year, depending on how the patient is. We have our students and the security, and each one plays a key role in the treatment. The next thing we say is that we have to individualize our treatment. Our patients are diverse. They have multiple comorbidities. So not one patient fits the shoe of another patient. They have different age groups. They come from different cultural groups, different socioeconomic groups, different levels of education. You can imagine trying to teach an elderly 8-year-old how to inject. and they cannot even read? How do you tell them to take 10 units? How do you teach a blind patient to inject insulin? And maybe they don't have someone to be with them. And here you have to use devices like pens and tell them that each click is 1 unit and you have to count the clicks. And you pray to God that they're going to inject the correct dosages. They come from diverse geographical regions. If you have a patient from Turkana and you're giving them insulin and the temperatures are 42 degrees, therefore they cannot keep that insulin in the room temperature. How do you treat that patient? Vis-a-vis a patient who's in Nairobi and has a fridge. So the treatment is individualized. And for appropriate care, you have to individualize everything from their goals to different, how are you going to involve the caregivers? The nurses assist a lot because they are able to identify the patients who are struggling. They see these patients who come every day, who come to the clinic. They're able to identify who is struggling, who has poor glycemic control, who has other comorbidities. They're able to screen for us because sometimes the patients can be so many. They can tell you this patient has got a diabetic wound and they're hiding, and you're able to examine and give the appropriate care. The nurse educators, who are the nurses, are able to train and initiate the insulin administration. How like the illiterate people, sometimes I see them put in a piece of maybe sellotape to mark where the insulin should be, or how to count those sticks and tell them you have to count 10 sticks and that is where your insulin will be, the level would be. So it takes time, it takes a lot of passion, but with all that, you're able to get individualized and good care. You have to individualize the nutritional requirement. A patient with heart failure vis-a-vis a patient with a chronic kidney disease vis-a-vis a patient with normal renal functions. You're not going to give them the same nutritional advice. So the nutritionist has to sit down, even when they get the diabetes education, they have to sit down with different patients and have an individualized care plan. The pharmacists also sit down with the patient because our patients have got multiple comorbidities. These are patients who will be on antihypertensives, will be on oral hypoglycemic, so insulin, will be on statins, will have arthritis, will have heart failure. So they have multiple medications. You find these are patients who might buy the drug. This time they find metformin is called glucomet. The next time they find metformin is glucodown. The next time they find metformin is glucophage. And they might think these are different drugs. So you find a patient is overdosing. So the pharmacist in our diabetes clinic sit down with the patients. They go through the prescriptions and make sure that the patient understands what specific medication they're taking, frequency of administration, and the right time to take. There's currently a team from the pharmacy department that is looking at alternative medicine. Most of our patients have visited herbalists and they come with a lot of questions. They're taking herbs. So there's a team that also sits down with them and talks about the alternative medication and which one is acceptable and what is not acceptable. And as this had already said, that every patient who comes to the clinic has a random blood sugar taken and will determine the appointment that will be given. And if the patient is a high risk, they are reviewed the same day. Other engagements is that we involve other corporates who donate for us glucometers, and we're able to donate to our patients so that they can be able to monitor their sugar control. We have constant training for our staff, CMEs, and the key thing is that we have to have teamwork so that we're able to put the patient as a center, because that is why we're there and we want them to have good control. Challenges that we say is that we face is that the patient numbers sometimes can be high. The staffing, the patient to nurse ratio, patient to doctor ratio sometimes is quite difficult to be able to have a proper care plan. The distance from the bus stop and the main tower to our clinic is difficult, such that if a patient is missing a file, you have to send someone to number 19 to pick up the files. But that, because of the teamwork and having very many people, that we're able to at least mitigate. But with time, we hope we'll have other better ways of facing this challenge. Financial constraints are also quite large. we find we want to give our patients something better, but because of finances, they're not able to overcome that. And the projects that we have in the pipeline that again are patient-centered, that we want to form transition clinics for our adolescents who are coming from the pediatric center. We don't want them to mix with the 80-year-olds or patients with amputees, and the adolescents will start thinking that that is where they're ending. We would want them to just be on their own. We also are in the process of forming different support groups for our patients so that we can share what difficulties they're going through and we understand them better and we're able to support them better. So thank you, and we are all welcome to our Diabetes and Endocrinology Center.
Thank you very much, Dr. Rosemary Wanjiru, and those are great projects that you're working on. We really appreciate that you're able to cater to the adolescents' needs and you're seeing through their eyes that they might be worried about the future, and that you're also thinking about having support organizations for the patients. One of the things, or the few things that I've caught throughout the three presenters, Dr. Christine Muse, Julie Matiba, and Dr. Rosemary Wanjiru have mentioned 8 things in common. The first one is shared decision-making. All presenters have talked about that. All presenters have talked about considering the patient's preferences and values, and they've all given examples that we can apply. They've talked about family involvement. They've talked about mutual agreement, where you agree with the patient and the patient understands. And for that mutual agreement to happen, they've said that information has to get to the patient very clearly so that the patient can be able to make an informed decision, and so that you can agree on a treatment plan together. They've also talked about coordination of care, whether it's through referral process or whether it's within the hospital, coordinating their care with the counselors, with the spiritual leaders, if that is their need or their preference, or if that is what they value, coordinating their care to other disciplines, healthcare-related disciplines that they need coordination of care with. They've also talked about individualized care. One patient's preference is not the other patient's preference. They've given examples of if you're talking to the elderly and talking to the young patient, a younger patient, how do we communicate so that they all understand this is the need? The 7th thing is a multidisciplinary team approach. And from what we're taking home is that patient-centered care is not a one cadre approach. It is a multidisciplinary team approach. And the 8th thing is access to care, whether it is physical distance or it is financial access to care. That is something that they've all talked about, and we appreciate that powerful presentation and for the good work that they've done. I can see there are 2 questions and some comments in the Q&A section. Yes, so the first question was determining the benefits of patient-centered care, and Dr. Christine Muse, maybe you could take that one. I've seen you, yes.
So how do we determine that care to the patient is patient-centered? We do this through the feedback of the patient. We have several ways of getting feedback. We do a customer satisfaction survey through an exit questionnaire so that the patients are open to say what they need to say when they're exiting home. We also have a compliments/complaints feedback, and this is analyzed regularly. We also speak to patients when we give care to them. We get a feedback, direct feedback, and that way you're able to tell whether the patient care is centered on the patient. And I would like to say that in the exit questionnaire, we have closed questions that help to rate help the patient to rate the care given, but we also have a session that have open comments, and therefore we are able to pick this from the patient. Now, in regards to patient customer satisfaction survey, they are done departmentally, they are done per unit, they are also done hospital-wide by both internal auditors and external auditors, and therefore there's a lot that we can pick from this. Thank you.
Thank you very much, Christine. Dr. Rosemary Wanjiru, what are some of the benefits you've seen as you put the patient in the center, as you have the goals of care, individualized goals of care for each patient? What are some of the benefits you've seen from diabetic clinic or at diabetic clinic?
Thank you. That's a good question. What we found is that when you individualize a care and you have it's patient-centered, the patient feels that you care about them, you understand their situation, and you find that they are more compliant. And when they have issues, they are able to come and talk to you and tell you, maybe this is not working because of 1, 2, 3. So you find overall, they have better control of their diabetes and better control of all other comorbidities. Because now what we say is that for diabetes, we do not want to be glucocentric, but we look at the whole patient in totality. We do not want excellent sugars, but the patient's kidneys are gone. So we are finding patient-centered care is markedly improving our patients' overall health.
Thank you. Thank you very much for that response. Julie, I can see you responded to the question about patient confidentiality and involvement of family members. Maybe you could, in brief, just make a comment on that. And also with regards to that, I've seen another question on what do we do when the patient doesn't want the family to be involved in the care? And similarly, another question in the chat, still in the same breath, that was asking about what happens if the family does not want the patient to know what he or she is suffering from. So there's families that feel they need to protect their patient. There are patients that feel they need to, the information should not be shared. And how do we draw that line where we give information, but we also do not breach the confidentiality? So Julie, if you're online, you could just maybe explain your answer, or as you have explained in the answer.
Thank you. Thank you, Dr. Kalondo. For me, from experience, I have seen involving the patient's family means involving them in their care. And that means that the patient is to identify the person, the most immediate caregiver or support person who will work with her, who will be there for them. So that now that is the person she identifies for you to be able to give information and share the support, especially while at home. But concerning confidentiality, that's also an ethical dilemma, because some patients feel they want information to be given, others feel they don't want it to be given. And when you look at patient-centered care, it means it's patient-centered. That's my view. Let the patient be, if they are be able to make decisions on their own. Sometimes you have children, and that becomes another dilemma, because now their family are the ones who make the decision, the parents. And then concerning the other issue of the family doesn't want the patient, then that is not patient-centered care. That's my view. Patient-centered care means you involve the patient, and that's where we go wrong. Because if it's an elderly mama, you will need to sit down with her and explain to the level that she'll understand. And if the family does not want to involve her, then that is not patient-centered care. That's my opinion. Thank you.
Thank you very much, Julie. And I do agree with you. Involving the patient or explaining to the patient, no matter the age difference or no matter what the family wishes, sometimes might be a good thing, especially when it comes to compliance to treatment and achieving good outcomes for the patient. There's a question, and as we have 1 minute to end the session, there's a question about having an SMS system or calling to alert relatives if the patient condition deteriorates. Still in the same breath, about online portal for booking appointments. I believe this is clinic appointments, or a USSD code for those without smartphones. So yes, these are very innovative ideas, and these are some of the great ideas that we need to start embracing in healthcare. Having a system of online booking for patients, especially in the public sector. You might find in private sector, it is working well, the online booking, but in public sector, we need to embrace telehealth and IT solutions better and more effectively. About the SMS system, this is a good idea. And I would like to just ask the audience, if you were, because we are all consumers of this healthcare system, if it was your relative or your loved one who's in hospital and you got an SMS or a call from the hospital, would it scare you? Would it encourage you to come immediately? Or how would it be? Because the solution also lies with us as healthcare providers. We are consumers, we are also the innovators, we are also the users of the system, and we are also the ones who can make this system better. So if you are in a position to, or if you are having your loved one, how would you feel about an SMS system or a call if the condition of your relative or loved one deteriorates? Like right now, if you have a patient admitted in KNH and you see KNH calling you, how can we communicate to the relatives or the clients and the family in a better way? The phone call is good, and it is good way of alerting the family to come. But also, as we break this bad news, and maybe one day Anne Kirema will give us a session on breaking bad news. As we break this bad news, how do we also not create more anxiety? How do we also create, give courage to the family that it is not all doom and gloom, or we're not calling them because their loved one has passed on? So as we create these systems, please let's also think about the wearer of the shoe and how they perceive it, and how we can have a counselor or train our teams to be able to support these processes, so that you don't receive a call telling you come to KNH immediately and you don't know what you're being called for. There's a way we can break the bad news. There's a way we can send an SMS if that is the preferred mode of communication, and still the patient or the family does not feel that it is a dire situation that you're calling them for. Thank you very much. And I believe we've addressed most of the questions that were there. Jonathan, Ducey, and Bramwell Kesa, yes, your comments are great. And I can see just in summary what Jonathan is saying. For us to sustain patient-centered care, we need to link patients to family physicians who are trained to offer patient-oriented care at home and the community, and to ensure coordinated, continuous, comprehensive patient-centered care in and outside the hospital. Bramwell is also talking about encouraging the patient to involve the trusted member of the family in their care. Yes, the involvement of the family has to start with the patient, where if the patient nominates a family member or two or three next of kin who they trust, who they value, and who they feel have their best interests at heart, then it makes that conversation easier between the healthcare workers and their family, so that we are also not divulging information to family who are not very close family members. But once we give the patient the autonomy to nominate, if they're in a conscious state, and as we start following them up, to nominate their loved ones who they feel would be great beneficiaries or would make good decisions on their behalf, then the conversation starts and becomes a very good encounter. So I hope we've gotten a few take home. The key take home is in your clinic, in your hospital, in your pharmacy, in your institution, in your office, is that you need to listen to the patient with care and with respect, and that we need to address their concerns. We need to understand their values and their preferences, and we've been told patients' values and preferences vary. They differ. They have different values and preferences. So as we bring changes in our setup or in our institutions, kindly let's consider our patient values. Let's be interested in knowing what is the patient experience as the patient exists, leaves your ward. what was the experience? Whether it was good or bad, it is an experience that will help you build, that will help you improve, that will help you shape your center to become a better facility. And we've learned a lot from Julie as she's presented the patient experiences in the oncology ward of what the patient has encountered, the patient's views about whether they had the holistic care, the comfort was taken care of, whether there was privacy, whether there was psychosocial needs and spiritual needs were taken care of, about communication, about healthcare workers sharing information and involving them, about empathy, about our attitudes as staff, about involvement of family and their support. And those are great lessons that we've learned from that particular research. We look forward to having you tomorrow for another day of the second day of the patient and family-centered symposium, still at the same time, 2 to 3:30 p.m. We will be having a different lineup, and this will be very great. So I hope you will all attend and learn something from it. And anyone who's done research on patient-centered care, feel free to reach out to us so that next time we're having a similar session, we can include you to present your research findings or what you've done differently in your institution. So you can reach out to Patient Affairs Unit at Kenyatta National Hospital, and Kirema is here. She'll also be available tomorrow together with our team of support team, and they should be able to link up with you, or through the research and programs department, you can share that information and your willingness. And who knows, maybe next month we could have another session just to hear what you're doing different and to learn from you. So thank you very much for attending this session. Have a good afternoon, and thank you to our presenters. Dr. Christine Muse, thank you very much for the valuable information that you've given us. Julie Matiba, thank you very much for that research. And I hope this is not the end of research from you, that we will get to hear a follow-up research from that, whether we've improved with your findings and with your results. And also Dr. Rosemary Wanjiru, thank you very much for sharing what you're doing at Diabetic Clinic and the individualized treatment, and that teamwork is key. Thank you to the presenters, and thank you for saying yes to this invite. Anne Kirema, Paul Ndungu, and Lucy Simoto, thank you for organizing this session. Bye, have a good afternoon.
Thank you, good afternoon.
Asante sana. Good afternoon.